Question 1. The 55-year-old male, Mr. Stevens, has a history of progressive memory impairment, including difficulty recalling recent events and appointments. He often confuses names of family members and experiences mild disorientation. His family reports that he frequently forgets to take his medication and has exhibited personality changes over the last few months. What is the most likely diagnosis for Mr. Stevens' condition? A. Parkinson's disease. B. Alzheimer's disease. C. Vascular dementia. D. Frontotemporal dementia. Answer: B. Alzheimer's disease. Explanation: Alzheimer's disease is the most common form of dementia in older adults, typically characterized by gradual onset and progressive memory loss, especially in short-term memory. The cognitive decline in AD is often accompanied by personality changes, disorientation, and difficulty with daily tasks as seen in Mr. Stevens. While Parkinson's disease and frontotemporal dementia can also cause cognitive decline, their presentation typically includes other motor or behavioral symptoms that are not the primary issue in this case. Vascular dementia is usually associated with history of stroke or other vascular issues, which is not indicated here. Question 2. The 35-year-old woman presents with chronic unexplained fatigue, dizziness, and difficulty concentrating. She reports a constant low mood and feeling of hopelessness for over 2 years, with intermittent periods of irritability. Her sleep is disturbed and she experiences poor appetite. After ruling out medical conditions, her symptoms best fit which diagnosis? A. Bipolar disorder. B. Generalized anxiety disorder. C. Major depressive disorder. D. Attention deficit hyperactivity disorder, EHD. Answer: C. Major depressive disorder. Explanation: Major depressive disorder, MDD, is characterized by a persistent low mood, fatigue, sleep disturbances, appetite changes, and difficulties in concentration. The patient's symptoms align with MDD, including the 2-year duration and the absence of other medical causes. Bipolar disorder is ruled out because the patient does not exhibit manic or hypomanic episodes. Generalized anxiety disorder primarily involves excessive worry, where EHD would involve attention difficulties without the mood disturbances observed here. Question 3, scenario-based. Mr. Anderson, the 48-year-old man, has been referred for psychiatric evaluation after experiencing escalating anxiety attacks, including palpitations, sweating, and shortness of breath, primarily when leaving his house. He is very concerned about going outside and frequently avoids social gatherings. His family reports that these symptoms have intensified over the last 6 months. What should the next step in treatment? For Mr. Anderson, A. Prescribe an SRE and schedule regular cognitive behavioral therapy CBT sessions. B. Refer for inpatient hospitalization due to severe anxiety. C. Initiate a benzodiazepine regimen to manage anxiety symptoms. D. Recommend the patient avoid all public spaces to reduce anxiety. Answer: A. Prescribe an SRE and schedule regular cognitive behavioral therapy CBT sessions. Explanation: Mr. Anderson's symptoms are consistent with panic disorder and agoraphobia, both of which respond well to combination of cognitive behavioral therapy CBT and selective serotonin reuptake inhibitors SRIs. SRIs are first-line pharmacological treatments for anxiety disorders. CBT is also highly effective, especially in addressing avoidance behaviors and cognitive distortions associated with anxiety. Hospitalization is not necessary unless there is imminent risk to safety, which is not the case here. Benzodiazepines are used for short-term symptom management, but are not ideal for long-term management due to their risk of dependence. Avoid counterproductive as it reinforces the patient's fear. Question 4. The 70-year-old male, Mr. Harris, presents with confusion, poor short-term memory, and difficulty performing everyday tasks like cooking and managing finances. His symptoms began gradually over the past year, and his wife has noticed that he often repeats the same questions in conversation. On cognitive testing, Mr. Harris scores poorly in memory recall and executive functioning, but his motor skills remain intact. Based on this presentation, what is the most likely diagnosis? A. Alzheimer's disease. B. Vascular dementia. C. Parkinson's disease dementia. D. Frontotemporal dementia. Answer: A. Alzheimer's disease. Explanation: Alzheimer's disease is the most common cause of dementia in older adults, typically presenting with gradual memory decline, particularly in short-term memory, as well as impairments in executive functioning. Mr. Harris's presentation, especially the progressive memory problems and preserved motor function, aligns well with AD. Vascular dementia often follows a series of strokes or has stepwise progression. Isn't indicated here. Parkinson's disease dementia would involve motor symptoms like tremors or rigidity early on, and frontotemporal dementia generally causes early personality changes, which are not reported in this case. Question 5. A 24-year-old female is diagnosed with obsessive-compulsive disorder, OCD. She experiences persistent intrusive thoughts about germs, which lead her to engage in compulsive hand-washing rituals for over 2 hours each day. She recognizes the irrationality of her actions, but feels compelled to perform them in order to reduce her anxiety. Which of the following treatment options is the most effective for managing this symptoms? A. Cognitive behavioral therapy CBT with exposure and response prevention. B. Atypical antipsychotics. C. Benzodiazepines. D. Electroconvulsive therapy ECT. Answer A. Cognitive behavioral therapy CBT with exposure and response prevention. Explanation. Cognitive behavioral therapy CBT with exposure and response prevention is the gold standard treatment for obsessive compulsive disorder or CD. Helps the patient confront the obsessive thoughts without performing the compulsive behaviors, which reduces the anxiety over time. Atypical antipsychotics are generally not first-line treatments for OCD. Benzodiazepines are used for acute anxiety management but do not address the underlying OCD symptoms. Electroconvulsive therapy ECT is typically reserved for severe, treatment-resistant cases of psychiatric disorders, not for the management of OCD. Question 6. A 42-year-old male presents with an acute onset of hallucinations, delusions, and disorganized speech. His symptoms developed over a few weeks and he appears highly agitated and confused. He has no history of psychiatric disorders or substance abuse. He reports recent high levels of stress due to work-related issues. Based on this presentation, what is the most likely diagnosis? A. Schizophrenia. B. Brief psychotic disorder. C. Major depressive disorder with psychotic features. D. Bipolar disorder with psychotic features. Answer. B. Brief psychotic disorder. Explanation. Brief psychotic disorder is characterized by the sudden onset of psychotic symptoms such as hallucinations, delusions, and disorganized speech lasting for at least 1 day but less than 1 month. This diagnosis is appropriate for someone experiencing a brief episode of psychosis following a stressful life event. Schizophrenia typically involves chronic symptoms that last for at least 6 months. Major depressive disorder with psychotic features would primarily include depressive symptoms and not the sudden onset seen here. Bipolar disorder with psychotic features would be associated with mood fluctuations and not just the psychotic symptoms. Question 7. Scenario-based. MS. Thompson, a 30-year-old woman, presents with severe social anxiety, leading her to avoid social situations and professional engagements. She often experiences a racing heart, sweating, and difficulty speaking when she is in public or even when thinking about attending a meeting. Her anxiety has significantly impaired her daily life and professional development. What is the most appropriate next step in treatment? Ms. Thompson, A. Initiate a trial of selective serotonin reuptake inhibitors, SRS, and offer cognitive behavioral therapy CBT. B. Recommend social avoidance and relaxation techniques. C. Prescribe a benzodiazepine for short-term relief. D. Refer her for inpatient psychiatric care. Answer A. Initiate a trial of selective serotonin reuptake inhibitors, SRS, and offer cognitive behavioral therapy CBT. Explanation. The combination of SRS and cognitive behavioral therapy CBT is considered the first-line treatment for social anxiety disorder, SAD. SRS help reduce the anxiety symptoms over time, while CBT addresses the underlying cognitive distortions and avoidance behaviors. Social avoidance and relaxation techniques are not ideal long-term solutions as they can exacerbate the disorder. Benzodiazepines may provide short-term symptom relief but are not suitable for long-term management due to their risk of dependence. Inpatient psychiatric care is not necessary unless there is a high risk of harm or the patient is unable to manage symptoms in an outpatient setting. Question 8. A 60-year-old male with a history of hypertension and smoking is admitted for an acute ischemic stroke. He presents with right-sided hemiparesis, aphasia, and facial droop. CT imaging confirms the presence of a stroke. Which of the following treatments would be most appropriate in the acute management of this patient? A. Administration of recombinant tissue plasminogen activator, RPA. B. Initiation of antiplatelet therapy. C. Hyperbaric oxygen therapy. D. Surgical resection of the ischemic tissue. Answer A. Administration of recombinant tissue plasminogen activator, RPA. Explanation: recombinant tissue plasminogen activator. RTPA is the first-line treatment for acute ischemic stroke within a 4.5-hour window from symptom onset. This treatment works by dissolving the clot and restoring blood flow to the affected brain area. Antiplatelet therapy is typically initiated after the acute phase to prevent further strokes, but is not used in the immediate management. Hyperbaric oxygen therapy and surgical resection are not indicated for ischemic strokes. Question 9. A 48-year-old female with a history of bipolar disorder presents for a routine checkup. She reports feeling depressed and hopeless despite being on a mood stabilizer, lithium, for several years. Her recent blood tests show a lithium level of 0.9 meckel, which is within the therapeutic range. What is the next best step in management? A. Increase the dose of lithium. B. Add an antidepressant to her regimen. C. Switch to an anticonvulsant mood stabilizer. D. Assess for non-adherence to lithium therapy. Answer: D. Assess for non-adherence to lithium therapy. Explanation: in a patient on lithium with a therapeutic level and persistent depressive symptoms, the next best step is to assess for non-adherence. Non-adherence is a common issue in bipolar disorder treatment and should be evaluated before making changes to the medication regimen. Increasing the dose of lithium or adding an antidepressant may not be effective and could even worsen symptoms if the patient is not taking the medication as prescribed. Switching to an anticonvulsant mood stabilizer is premature without first evaluating adherence to the current treatment. Question 10. A 33-year-old male presents with a history of intermittent intense fear of being in social situations, leading to avoidance of work meetings and family gatherings. He reports sweating, trembling, and nausea when confronted with social interactions, but he can function in one-on-one situations. His symptoms have persisted for over a year. What is the most likely diagnosis? A. Panic disorder. B. Social anxiety disorder. C. Generalized anxiety disorder. D. Specific phobia. Answer: B. Social anxiety disorder. Explanation: social anxiety disorder, SAD, is characterized by significant fear of social situations where the individual is exposed to possible scrutiny by others. The symptoms described, including physical anxiety symptoms in social contexts, point to SAD rather than panic disorder, which involves unexpected panic attacks in a variety of situations, not just social ones. Generalized anxiety disorder involves pervasive worry across various domains, and specific phobia is usually linked to a specific identifiable object or situation, not social interactions. Question 11. A 45-year-old woman with a history of depression presents to the clinic with complaints of feeling excessively tired, gaining weight, and experiencing cold intolerance. She also reports constipation, dry skin, and thinning hair. Upon examination, her thyroid is palpably enlarged. Her thyroid function tests reveal an A level of 15 mol, normal range 0.4, 4.0 mol, and Freet is low. The most likely diagnosis: A. Graves' disease. B. Hashimoto's thyroiditis. C. Subclinical hypothyroidism. D. Hypopituitarism. Answer: B. Hashimoto's thyroiditis. Explanation: the patient's clinical presentation, including fatigue, weight gain, cold intolerance, constipation, dry skin, and hair thinning, along with the elevated TH level and low Freet, is consistent with hypothyroidism. Hashimoto's thyroiditis is the most common cause of hypothyroidism and is an autoimmune condition in which the body attacks the thyroid gland. Graves' disease typically hypothyroidism and would present with symptoms like weight loss and heat intolerance. Subclinical hypothyroidism would have normal level, and hypopituitarism would present with more generalized pituitary dysfunction. Question 12. A 58-year-old male with a history of hypertension presents with sudden onset chest pain radiating to his back. He also reports shortness of breath and lightheadedness. On examination, his blood pressure is 200/100 Hg, and there is a discrepancy in blood pressure between his arms. A chest X-ray shows widening of the mediastinum. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Pericarditis. Answer: B. Aortic dissection. Explanation: the sudden onset of severe chest pain radiating to the back, along with elevated blood pressure, arm blood pressure discrepancy, and mediastinal widening on chest X-ray, strongly suggest an aortic dissection. Aortic dissection occurs when there is a tear in the aortic wall, leading to blood entering the vessel wall and causing a split. Acute myocardial infarction typically presents with chest pain, but not. A blood pressure discrepancy. Pulmonary embolism presents with chest pain, shortness of breath, and hypoxia, but not the other features seen here. Pericarditis often causes pleuritic chest pain, but it doesn't cause the same signs. Question 13. A 25-year-old female with a history of generalized anxiety disorder presents with complaints of excessive worry about work, school, and personal relationships. She has trouble controlling the worry, which occurs most days. For the past 6 months, she has difficulty sleeping, feels fatigued, and has muscle tension. What is the most likely diagnosis? A. Major depressive disorder. B. Generalized anxiety disorder. C. Panic disorder. D. Adjustment disorder. Answer: B. Generalized anxiety disorder. Explanation: generalized anxiety disorder (GAD) is characterized by excessive worry that is difficult to control, occurring more days than not for at least 6 months, along with physical symptoms such as fatigue, muscle tension, and sleep disturbances. Major depressive disorder involves persistent low mood and lack of interest, which is not the case here. Panic disorder involves recurrent panic attacks and future attacks, which is not described in this scenario. Adjustment disorder involves stress-related symptoms after a specific stressor but does not fit the duration and chronicity described. Question 14, scenario-based. A 72-year-old male presents to the emergency department with sudden loss of vision in his right eye. He describes it as a shadow covering his vision. His medical history includes hypertension, diabetes, and hyperlipidemia. On examination, his visual acuity is 20/200 in the right eye, and there is a relative afferent pupillary defect. Fundoscopy reveals a pale retina with a cherry red spot at the macula. What is the most likely diagnosis? A. Retinal artery occlusion. B. Retinal vein occlusion. C. Diabetic retinopathy. D. Age-related macular degeneration. Answer: A. Retinal artery occlusion. Explanation: the sudden loss of vision in one eye accompanied by a relative afferent pupillary defect and the finding of a cherry red spot on fundoscopy is characteristic of retinal artery occlusion. RAO. The cherry red spot occurs due to the contrast between the ischemic retina and the preserved macula. Retinal vein occlusion typically causes retinal hemorrhages and dilated veins. Diabetic retinopathy, vision loss, but typically develops more gradually and is associated with microaneurysms, hemorrhages, and exudates. Age-related macular degeneration leads to central vision loss but does not present with the acute symptoms and cherry red spots seen here. Question 15. A 19-year-old female presents with chronic pelvic pain, dysmenorrhea, and dyspareunia. She also reports pain during bowel movements and a history of irregular menstrual cycles. On pelvic examination, there is tenderness in the posterior fornix, and laparoscopy reveals endometrial-like tissue on the ovaries and the posterior pelvic peritoneum. What is the most likely diagnosis? A. Ovarian cyst. B. Endometriosis. C. Pelvic inflammatory disease. D. Irritable bowel syndrome. Answer: B. Endometriosis. Explanation: endometriosis is characterized by the presence of endometrial-like tissue outside the uterus, commonly affecting the ovaries and the posterior pelvic peritoneum. The chronic pelvic pain, dysmenorrhea, and dyspareunia are typical symptoms, and the pain during bowel movements is suggestive of bowel involvement. Ovarian cysts can cause pelvic pain, but are typically not associated with the same symptoms. Pelvic inflammatory disease often presents with fever, vaginal discharge, and pelvic tenderness, not the chronic pain described here. Irritable bowel syndrome can cause abdominal pain and changes in bowel habits, but doesn't account for the pelvic findings on laparoscopy. Question 16. A 30-year-old male presents with a 1-week history of fever, malaise, and joint pain, particularly in his knees and wrists. He reports a recent sore throat and a rash that appeared on his arms and legs. On examination, there are erythematous maculopapular lesions on his extremities and a small, non-tender swelling over his metacarpophalangeal joints. What is the most likely diagnosis? A. Rheumatic fever. B. Infectious mononucleosis. C. Systemic lupus erythematosus. D. Viral exanthem. Answer: A. Rheumatic fever. Explanation: this patient's symptoms of fever, malaise, joint pain, especially migratory arthritis, and recent sore throat are highly suggestive of rheumatic fever, which often occurs after group streptococcus throat infection. The erythematous macular papular rash, known as erythema marginosum, and non-tender swelling over the joints, likely migratory polyarthritis, are classic findings. Infectious mononucleosis, presence with sore throat, fever, and lymphadenopathy, but not with the specific joint symptoms seen here. Systemic lupus erythematosus often has more persistent, widespread symptoms including malar rash, but the patient's history and presentation are not consistent with lupus. Viral exanthem can cause rash but lacks the specific findings seen in this case. Question 17. A 55-year-old woman presents with progressive shortness of breath, cough, and fatigue over the past 6 months. She has a history of smoking 30 pack years. On examination, she has a barrel chest, diminished breath sounds and prolonged expiration. Spirometry reveals a FEF ratio of 60% and a forced expiratory volume in 1 second. FEF of 45% predicted. What is the most likely diagnosis? A. Asthma. B. Chronic bronchitis. C. Emphysema. D. Pulmonary fibrosis. Answer C. Emphysema. Explanation: the patient's history of smoking progressive, shortness of breath, cough, and physical findings. Barrel chest, diminished breath sounds and prolonged expiration suggest chronic obstructive pulmonary disease, COPD, with emphysema being the most likely type in this case. The spirometry results showing reduced FEV ratio and significantly reduced FEV support the diagnosis of obstructive lung disease. Asthma typically presents with reversible airflow obstruction, which would not be seen with such persistent reduction in lung function. Chronic bronchitis is also a form of COPD, but the predominant features would be chronic cough and sputum production, which the patient does not mention. Pulmonary fibrosis would present with restrictive lung disease, which is not consistent with the obstructive pattern seen here. Question 18. A 60-year-old male with a history of alcohol use disorder presents with confusion, ataxia, and nystagmus. He is unable to recall recent events and has difficulty maintaining balance when standing. His gait is wide and unsteady. What is the most likely diagnosis? A. Wernicke-Korsakoff syndrome. B. Acute alcohol intoxication. C. Cerebellar stroke. D. Multiple sclerosis. Answer A. Wernicke-Korsakoff syndrome. Explanation: Wernicke-Korsakoff syndrome is a neurological disorder most commonly associated with chronic alcohol use and thiamine vitamin B deficiency. The classic triad of symptoms includes confusion, ataxia, and nystagmus, which this patient exhibits. The inability to recall recent events and retrograde amnesia is a hallmark of Korsakoff psychosis, which often follows Wernicke's encephalopathy. Acute alcohol intoxication may cause confusion and ataxia, but it wouldn't cause persistent symptoms like this patient's. Cerebellar stroke would present with sudden onset ataxia and may involve other neurological deficits. Multiple sclerosis could present with ataxia, but would typically involve other findings such as visual disturbances or sensory changes. Question 19. A 45-year-old woman presents with intermittent, crampy abdominal pain that is relieved by passing gas or stool. She reports bloating and changes in her bowel habits with periods of diarrhea and constipation alternating. She has no weight loss or blood in her stool. What is the most likely diagnosis? A. Irritable bowel syndrome. B. Celiac disease. C. Inflammatory bowel disease. D. Colon cancer. Correct answer A. Irritable bowel syndrome. Explanation: irritable bowel syndrome is a functional gastrointestinal disorder characterized by intermittent abdominal pain, bloating, and altered bowel habits, diarrhea, and constipation alternating, often relieved by defecation. The absence of weight loss, blood in the stool, or other alarming features makes inflammatory bowel disease or colon cancer less likely. Celiac disease would present malabsorption symptoms, including weight loss and nutrient deficiencies, and would typically show positive serology for anti-tissue transglutaminase antibodies. Question 20, scenario-based. A 23-year-old woman presents to the clinic with complaints of fatigue, palpitations, and weight loss despite a normal appetite. On examination, she is found to have a tremor, heat intolerance, and an enlarged thyroid gland. Her TSH level is low and free T is elevated. What is the most likely diagnosis? A. Hyperthyroid Graves' disease. B. Hypothyroid Hashimoto's thyroiditis. C. Thyroid cancer. D. Subclinical hypothyroidism. Answer A. Hyperthyroid Graves' disease. Explanation: the patient's symptoms of fatigue, palpitations, weight loss, tremor, heat intolerance, and an enlarged thyroid gland, along with low TH and elevated free T, that are consistent with hypothyroidism. Graves' disease is the most common cause of hyperthyroidism and is an autoimmune disorder that leads to the overproduction of thyroid hormones, the presence of tremor, and heat intolerance is also of this condition. Hashimoto's thyroiditis usually causes hypothyroidism, not hyperthyroidism. Thyroid cancer typically presents with solitary nodule and would not explain the diffuse symptoms of hyperthyroidism. Subclinical hyperthyroidism would show normal thyroid hormone levels with suppressed TS8. Question 21. A 50-year-old male with a history of hypertension and smoking presents with sudden onset chest pain radiating to his back associated with diaphoresis and shortness of breath. On examination, his blood pressure is 100/100 mmHg and he has a decreased pulse in the left arm. A chest X-ray shows a widened mediastinum. What is the most likely diagnosis? A. Myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Acute pericarditis. Answer: B. Aortic dissection. Explanation: aortic dissection is characterized by sudden onset severe chest pain radiating to the back, often described as a tearing or ripping sensation. His patient's risk factors, hypertension and smoking, and the physical exam findings of widened mediastinum and asymmetric pulses, decreased pulse in the left arm, are consistent with an aortic dissection. Myocardial infarction could cause chest pain, but would not present with radiating pain to the back and differential pulse pressures. Pulmonary embolism presents with sudden shortness of breath and pleurisy chest pain, but lacks the specific signs of aortic dissection. Acute pericarditis presents with pleurisy chest pain, but there would be no mediastinal widening or asymmetry of pulses. Question 22. A 27-year-old male presents with a persistent, non-productive cough, fatigue, and night sweats for the past 2 weeks. He recently returned from a trip to Southeast Asia. On examination, his temperature is 38.2 to 100.8 deg, and he has localized lymphadenopathy. Chest X-ray shows cavitary lesion in the upper lobe of the right lung. What is the most likely diagnosis? A. Tuberculosis. B. Pneumonia. C. Bronchitis. D. Sarcoidosis. Answer: A. Tuberculosis. Explanation: the patient's persistent cough, fatigue, night sweats, and recent travel to Southeast Asia, coupled with the chest X-ray findings of cavitary lesions, strongly suggest tuberculosis. TEB commonly presents with chronic cough, fever, night sweats, and weight loss, and can cause cavitary lung lesions on chest X-ray. Pneumonia may present with similar symptoms, but would more likely cause consolidation cavitation. Bronchitis typically causes cough but does not result in the other systemic symptoms or radiographic findings see here. Sarcoidosis can cause lung lesions but would more commonly involve bilateral hilar lymphadenopathy and granulomatous inflammation. Question 23. A 34-year-old woman presents with a 3-month history of painful, swollen joints, particularly in the morning. She has also noticed stiffness in her hands, especially after prolonged rest. On examination, there is swelling and tenderness over her metacarpophalangeal joints and wrists. Her rheumatoid factor is positive. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Osteoarthritis. C. Systemic lupus erythematosus. D. Psoriatic arthritis. Answer: A. Rheumatoid arthritis. Explanation: rheumatoid arthritis (RA) is an autoimmune condition that causes symmetric joint pain, morning stiffness, and swelling, particularly in the small joints of the hands and wrists. The patient's positive rheumatoid factor and typical presentation of prolonged morning stiffness support the diagnosis of RA. Osteoarthritis is characterized by joint pain with activity, but it typically affects larger joints and is not associated with prolonged morning stiffness or positive rheumatoid factor. Systemic lupus erythematosus can cause joint symptoms, but is usually accompanied by other systemic features like malarash and kidney involvement. Psoriatic arthritis may also affect the joints, but it is often associated with skin changes like psoriasis. Question 24. A 65-year-old man with a history of alcohol use presents with a 2-week history of increasing confusion, jaundice, and ascites. On examination, he is icteric and has a distended abdomen with shifting dullness. His liver span is enlarged and he has asterixis. What is the most likely diagnosis? A. Cirrhosis with hepatic encephalopathy. B. Acute hepatitis. C. Hepatocellular carcinoma. D. Alcoholic fatty liver disease. Answer: A. Cirrhosis with hepatic encephalopathy. Explanation: The patient's history of alcohol use, along with the signs of confusion, hepatic encephalopathy, jaundice, ascites, and enlarged liver, is most consistent with cirrhosis complicated by hepatic encephalopathy. The presence of asterixis flapping tremor also suggests hepatic encephalopathy, which occurs due to the accumulation of toxins like ammonia in the bloodstream when the liver is unable to detoxify them. Acute hepatitis typically presents with jaundice but would not cause the chronic signs and symptoms seen in this patient. Hepatocellular carcinoma can cause liver failure but would not explain the encephalopathy and ascites in the absence of other findings like mass on imaging. Alcoholic fatty liver disease may cause liver enlargement and dysfunction but does not typically lead to the severe complications seen here. Question 25. A 5-year-old child presents with a sudden onset of a high fever, sore throat, and a bright red rash that has a sandpaper-like texture. On examination, the child also has a strawberry tongue and pharyngeal erythema. What is the most likely diagnosis? A. Scarlet fever. B. Measles. C. Rubella. D. Fifth disease. Answer A. Scarlet fever. Explanation. Scarlet fever caused by group of Streptococcus gas presents with a high fever, sore throat, and a characteristic sandpaper-like rash which is most prominent in the neck, chest, and groin. The presence of a strawberry tongue, red bumpy tongue, and pharyngeal erythema further supports this diagnosis. Measles typically presents with a maculopapular rash starting on the face and spreading, along with a cough, coryza, conjunctivitis. Rubella causes a mild rash and is associated with lymphadenopathy. Fifth disease caused by parvovirus B presents with a slapped cheek rash, but it does not cause the sandpaper-like texture of the rash seen here. Question 26. A 50-year-old woman with a history of type 2 diabetes mellitus presents with a non-healing ulcer on her right foot. She reports numbness and tingling in her feet for the past 6 months. On examination, she has a large ulcer on the plantar aspect of her foot with the surrounding area of erythema. There is diminished sensation to light touch and pinprick in both feet. What is the most likely diagnosis? A. Diabetic neuropathy with foot ulcer. B. Cellulitis. C. Deep vein thrombosis. D. Peripheral artery disease. Answer A. Diabetic neuropathy with foot ulcer. Explanation. This patient's history of diabetes mellitus and the presence of non-healing ulcer, along with symptoms of sensory loss in the feet, numbness, and tingling, are characteristic of diabetic neuropathy. The neuropathy predisposes patients to foot ulcers due to impaired sensation, leading to unnoticed injury or pressure. Cellulitis could cause erythema around the ulcer, but it would typically present with fever. More acute onset. Deep vein thrombosis is unlikely, as it presents with leg swelling and pain. Peripheral artery disease could cause ulcers, but is associated with more pain, especially at night, and diminished pulses. Question 27. A 40-year-old male presents with progressive fatigue pallor and a history of easy bruising and frequent nosebleeds. His hemoglobin is 8.2 grams tall, platelets are 50,000 mol, and his white blood cell count is 1,500 mol. Bone marrow biopsy shows hypercellularity with blasts making up 30% of the marrow. What is the most likely diagnosis? A. Acute myelogenous leukemia. B. Aplastic anemia. C. Iron deficiency anemia. D. Vitamin B deficiency. Answer A. Acute myelogenous leukemia. Explanation. This patient presents with anemia, thrombocytopenia, and leukopenia, along with hypercellular bone marrow showing blasts. These findings are characteristic of acute myelogenous leukemia, a type of cancer that affects the bone marrow and results in the accumulation of immature white blood cells. Blasts. Aplastic anemia would cause pancytopenia, all cell lines reduced, but hypercellularity on bone marrow biopsy. Iron deficiency anemia and vitamin B deficiency would cause anemia, but they would not lead to the marked marrow changes seen in this patient. Question 28. A 62-year-old woman with a history of smoking presents with a chronic cough, weight loss, and hemoptysis. A chest X-ray reveals a central mass in the right lung. A biopsy shows squamous cell carcinoma. What is the most likely cause of her symptoms? A. Lung cancer. B. Pulmonary tuberculosis. C. Chronic bronchitis. D. Lung abscess. Answer A. Lung cancer. Explanation. This patient's chronic cough, weight loss, hemoptysis, and chest X-ray findings are suggestive of lung cancer, specifically squamous cell carcinoma, which is often centrally located. Smoking is the major risk factor for lung cancer, and squamous cell carcinoma is commonly associated with this history. Pulmonary tuberculosis typically presents with chronic cough, weight loss, and hemoptysis, but it would also be accompanied by fever and night sweats. Chronic bronchitis can cause chronic cough, but it would not cause weight loss or mass on imaging. Lung abscess typically presents with fever, purulent sputum, and localized consolidation on imaging. Question 29. A 70-year-old man presents with an episode of sudden onset severe back pain following a fall. He has a history of osteoporosis. On examination, there is tenderness over his lumbar spine, and he is unable to stand up straight due to pain. X-ray shows a compression fracture of LL. What is the most appropriate next step in management? A. Bed rest and pain management. B. Surgical intervention to stabilize the fracture. C. Vertebroplasty or kyphoplasty. D. Initiation of bisphosphonates. Answer C. Vertebroplasty or kyphoplasty. Explanation. This patient with a compression fracture of L and a history of osteoporosis should be considered for vertebroplasty or kyphoplasty, which are minimally invasive procedures used to stabilize the fracture and relieve pain. Bed rest and pain management are important initially, but they do not address the underlying fracture instability. Surgical intervention is generally reserved for fracture. Neurological compromise or severe deformity. Bisphosphonates are useful in treating osteoporosis and preventing future fractures, but they are not an immediate treatment for a current fracture. Question 30. A 25-year-old woman presents with a history of recurrent headaches, visual disturbances, and a change in her menstrual cycle. On examination, she has bilateral papilledema, and her blood pressure is 130/80 for VMT. Her ichne of the brain reveals an enlarged cella turcica. What is the most likely diagnosis? A. Pituitary adenoma. B. Multiple sclerosis. C. Brain tumor. D. Meningitis. Answer A. Pituitary adenoma. Explanation. The patient's symptoms of recurrent headaches, visual disturbances, and menstrual changes, along with bilateral papilledema and an enlarged cella turcica on CT, are consistent with pituitary adenoma. These tumors can cause increased intracranial pressure, leading to headaches and papilledema, as well as hormonal imbalances that affect the menstrual cycle. Multiple sclerosis typically present. Neurologic deficits, including motor or sensory changes, rather than isolated visual disturbances. Brain tumor could also cause headaches and visual changes, but would more likely present with additional neurological findings. Meningitis would cause fever, neck stiffness, and alter mental status, which are not present in this patient.